I'm Professor Nick James. I'm Professor of Prostate and Bladder Cancer Research at the Institute of Cancer Research and Consultant Clinical Oncologist at the Royal Marsden Hospital, both of those institutions being in London. So what we set out to do in the BladderPath study is to build on essentially the recent developments in imaging that have driven an awful lot of change in prostate cancer. So we know with prostate cancer, if you use MR upstream of biopsy, you get more accurate diagnosis. You're more likely to hit the bad bits of the tumor, and you spare people biopsies potentially if they've got low risk lesions. So the impact of MR in bladder, in prostate, has been huge, and certainly in the UK, it's transformed the pathway. Bladder cancer, on the other hand, has been stuck with a diagnostic model dating back a century of using a surgical procedure to do both the histology and the initial staging. Now, in order to switch to an image-based pathway, essentially what we did in the trial was to adapt the MR the MR schedules and schemes that we currently use in prostate. So most departments that have a busy prostate pathway will not find it too difficult to adapt that to including bladder in the same pathway, because they're using the same machines, the same sequences on their MR scanners. And there's a published already image analysis thing called VIRADS, so by analogy, very similar to PIRADS, which will be broadly familiar to the radiologists and the clinicians involved. So we think all of the elements are there already, but it will require a willingness to really think quite differently about the order in which you do things for patients with bladder cancer. Yeah, so what we set out to do was, the hypothesis was that if you have image-directed therapy, you'll make quicker, smarter decisions. So because when we set it up, we didn't think there was going to be much gain from doing MR scans on patients with very low-grade small lesions. And so we asked the urologist doing the initial flexible cystoscopy to identify patients with likely non-invasive disease. And it turned out they were very good. So the patients that they thought in the trial were largely going to be non-invasive, 98% of them were indeed non-invasive. So we confined the scan protocol to patients with possible muscle invasion, so the bad end of the non-invasive spectrum and the actual muscle invasives. And that was about 50% of the total, and 50% of those patients, i.e. 25% of the total, turned out to be muscle invasive within the trial. Now, as you say, the endpoint of the trial was time to correct treatment. So for that 50% who had the MR scans, if you were determined to have non-muscle invasive disease by whatever you got in the trial, then the correct treatment was deemed to be TURBT. If, on the other hand, you were deemed to be muscle invasive, the correct treatment now became either the first of surgery, radiotherapy, chemotherapy, or palliative care. So for those patients who are now not necessarily getting a TURBT, they had, as a minimum, a bladder biopsy. Now, if the clinician felt they needed something extra, either a full or a limited TURBT, either to be sure about the histology or for the reasons you outlined, like variant histology, things like that, extensive CIS being two examples, they could still have a TURBT, but it didn't stop the clock. So around half of the muscle invasives got a TURBT as part of their subsequent workup, but they still ended up getting to their definitive treatment faster. So what we think was happening in those patients was that if you have a policy where everybody gets a TURBT, you've then got a problem. You've got a large number of TURBTs to deliver. And what tends to happen is that they just put in a queue and then there's no prioritization. Whereas having done the MR first, you knew which the really bad patients were. And we think those got fast tracked through the TURBT and or the TURBT is done by the most senior clinician, because we know that who does these sorts of procedures is important. Because what we saw was the time to TURBT in the non-invasives came down on the MR arm, even though they'd had an extra scan, and the time to surgery, radiotherapy and so on came down substantially. It came down from an average of 100 days, just under, to just over 50 days on the MR targeted pathway for that subgroup. So it was a big effect. Just with respect to things like variant histologies, so we included in the trial anybody that had a bladder mass. So, for example, a number of the patients, it was determined that the correct treatment was palliative care. You don't particularly need to know much about the variant histologies and so on, because if you've got an MR scan showing somebody's got a bulky T4 tumour and METs, metastases, you can just make a decision to palliative care. And so those decisions were made much faster with an image-directed pathway, and you don't need any extra histology. For the subset of patients where you did need extra information, it doesn't stop you going in and getting it, but the evidence was it didn't stop you getting to the right treatment more quickly. So concerning the question of histopathology, so one of the things about TURBT is that itself is not very accurate for identifying variant histology. So if you look at patients identified as pure squamous carcinoma and on TURBT, a substantial proportion of those, maybe as many as half, turn out to be standard urothelial carcinomas when you do a cystectomy subsequently. And so there's actually not very good concordance. If, on the other hand, what you're interested in is, for example, FGFR3 mutations, then we've separately published a number of papers, as have other groups, showing that you can obtain tumor DNA from the urine of bladder cancer patients. So we've published a number of papers on this, as have other groups. And what we've shown is that if you've got, for example, an FGFR3 mutation in your bladder tumor, you can identify it in cell-free urine very accurately in nearly 100% of cases. So for other tumor types where we need to genotype, so prostate cancer, for example, with BRCA mutations, we know that for a substantial proportion of patients, you can get these from cell-free DNA in blood. So I think there are other evolving technologies that will allow us to profile the tumor biology without needing to do large-scale resections. And we can already do tumor profiling on very small biopsies from prostate cancer patients. There's no reason why we can't do the same thing on endoscopic biopsies. We obtain tissue by biopsy on the majority of the patients on the MR pathway, and depending on what you want to do with it, you can, for example, do Affymetrix or Decipher type profiling on very small amounts of tissue. So we're building that into the next round of our research. So in terms of implementation, if you're in a centre that is already doing prostate MRI as part of your prostate pathway, which is essentially every single centre in the UK, for example, now that is the standard of care, then you won't find it very hard to move to also scanning your bladder patients. You're using broadly the same sequences. It's the same radiologists that are going to be looking at them. It's the same multidisciplinary team meetings the patients are going to be coming through. What we found when we set the trial up was that early on, centres tended to do TURBTs after the MR, presumably because they didn't have complete confidence in what the MR was telling them. As the trial went on, they were less likely to do that. So there is clearly a learning curve if you move to a new thing, a new imaging modality. But the beauty of imaging as opposed to a surgical staging procedure is, of course, you can ask somebody else to review it. So it's perfectly possible, and this was what happened with the MR prostate pathway, to set up mentoring so that centres that do this already can help interpret the images for the centres that don't. And the numbers involved, so the triage I described, where you only do the MRs on the possible muscle invasives, you straight away get rid of half of your bladder cancer patients because they really don't benefit from it. And so the numbers are much less than the numbers having prostate MR. So the workload impact is not so great. And so getting mentoring and stuff is not such a challenge. So yes, for sure, there will be a learning curve. but I think it won't be so hard to move up as it was moving to prostate MR was a few years ago. So reproducibility is always an issue with any technique, of course. And as we discussed, there will be a learning curve. But I think if you're doing prostate MRIs already, that learning curve is not so hard. This was a multi-centre trial. It wasn't just a trial carried out in a single or small number of specialist centres. And the results appear to be very consistent across all of our trial centres. They were all busy NHS centres, not, I mean, some of them are more specialist than others, but we don't think there's any particular reason why these results are not generalisable. After we started the trial, there was a very important publication describing a classification scheme called VIRADS, VIRADS, so very similar to PIRADS. And in fact, two of the authors on the presentation I did this week are also authors on the VIRADS paper. Because we'd started the trial before the virus thing was published, it wasn't part of our primary analysis plan, but we are currently reclassifying, pulling in all of the scans that we obtained and reclassifying them according to the VIRAD scheme to actually use the study as a further round of validation for the VIRAD scheme. So I think that a standard classification system already exists, and we will be able to publish recommendations on how you would use this sort of MRI-driven pathway using the VIRADS scheme. We broadly were using the techniques in VIRADS because we've helped drive the VIRADS scheme, but we will produce a formal paper on this.